Degenerative cervical myelopathy, or DCM, along with cervical spondylotic myelopathy, represents the most common cause of non-traumatic spinal cord dysfunction in the adult population. The disease rarely announces itself. It presents insidiously. A patient might notice a slight loss of hand dexterity when buttoning a shirt, or develop a wide-based, slightly ataxic gait over several months. Frontline clinicians frequently misattribute these subtle early deficits to normal aging or an isolated radiculopathy, allowing the underlying pathology to advance unchecked. This MRI reveals a progressive structural disease driven by mechanical compression. Notice the visible, healthy cerebrospinal fluid space above and below the severe focal disc herniation, indicated by the red arrow, which is actively compressing the spinal cord. By mapping specific anatomical pathways to this compressive pathology, clinicians can recognize the early clinical signature, expedite advanced imaging, and initiate surgical intervention before ischemic damage becomes permanent. Because the onset is highly deceptive, maintaining a strict clinical suspicion of upper motor neuron signs is the single most important factor in preventing irreversible paralysis in aging patients. The pathobiology of DCM requires two distinct mechanical forces to cause injury: static and dynamic compression. Static factors narrow the spinal canal over time. These include acquired intervertebral disc bulging, the growth of vertebral body osteophytes, and the ossification of the posterior longitudinal ligament. Dynamic factors compound this narrowing. Repetitive microtrauma occurs not from extreme injury, but during a normal, everyday range of cervical motion. During cervical flexion, the biomechanics of the neck cause the spinal cord to stretch tightly over those vensal osteophytes. Conversely, during extension, the hypertrophied ligamentum flavum buckles dorsally, pushing directly into the spinal canal. This repetitive, pincering mechanical stress physically stretches the anterior spinal and radicular arteries across the surrounding structures. Chronic stretching and venous congestion drastically reduce vascular flow. The result is localized spinal cord ischemia. The cellular consequence of this ischemia is severe. Highly metabolic, vascular-dependent oligodendrocytes are starved of energy and undergo apoptosis. This localized cellular death leads directly to irreversible neural demyelination along the affected spinal tracts. The engine of DCM is the vascular strangulation that causes ischemic cell death, driven by the mechanical pinch of neural tissue. This cross-sectional diagram of the spinal cord connects the ischemic damage directly to specific functional deficits by mapping the three primary white matter tracts surrounding the central gray matter. Posterior compression here interrupts the dorsal columns, which carry ipsilateral vibration and proprioception signals. Damage to these specific columns produces the classic wide-based ataxic gait, as the brain loses spatial awareness of the lower extremities. It also triggers Lermet's sign, an electrical shock sensation radiating down the spine upon neck flexion, directly linked to dorsal column stress. Looking at the red sections on this diagram, we find the lateral corticospinal tracts. Compression here interrupts descending upper motor neuron control. This interruption manifests as upper motor neuron signs: ipsilateral lower extremity weakness, hyperreflexia, and spasticity. This table outlines the specific clinical tests used to confirm spasticity, an abnormal Babinski sign, and a positive Hoffman sign. Returning to the cross-section, the blue spinothalamic tracts are located in the anterior segment. Because these fibers cross over within the spinal cord, disruption in this anterior region causes a contralateral loss of pain and temperature sensation. A patient's diverse constellation of symptoms forms a direct, readable anatomical map, indicating precisely where the spinal cord is being starved of blood. A definitive diagnosis requires correlating these physical exam findings with advanced imaging. Standard AP and lateral X-rays, including flexion and extension views, should be ordered first to assess dynamic instability and overall cervical alignment. Magnetic resonance imaging is the gold standard for visualizing soft tissue. This T2-weighted MRI shows severe effacement of the cerebrospinal fluid space, distinct spinal cord deformation, and intramedullary hyperintensity, a bright signal indicating edema or myelomalacia. However, low signal intensity on a T1-weighted scan is a critical, ominous finding. This T1 low signal indicates permanent necrotic cord damage, serving as a primary predictor of poor postoperative recovery. Electrophysiology, such as an EMG, is rarely used to diagnose DCM directly, but it remains highly valuable for ruling out neurological mimics like ALS or peripheral neuropathy. Advanced imaging dictates whether the spinal cord has suffered reversible swelling or permanent necrosis. This flowchart illustrates the clinical management matrix, which is primarily dictated by disease severity using the Neuric or modified JOA scales. Following the mild pathway, conservative management is an option, strictly reserved for non-progressive cases. Modalities like cervical collars, physical therapy, and NSAIDs lack high-level evidence for reversing symptoms. Patients on this path require intense, regular monitoring for any stepwise deterioration. Following the moderate to severe pathway, DCM is a surgical disease. Decompression is required to halt progression. An anterior surgical approach, such as an ACDF or corkectomy, is utilized to address ventral compression and correct severe kyphosis. A posterior surgical approach, like a laminoplasty or laminectomy, is ideal for multi-level involvement of 3 or more segments, or cases of congenital stenosis. The primary medical goal of surgery is to halt further progression. Complete neurological recovery is unpredictable. Despite this unpredictability, outcome data indicates that 50 to 75% of surgical patients do experience significant functional improvement. This post-surgical neurological improvement typically plateaus at 6 months, making intensive post-operative rehabilitation critical during this brief window. For moderate to severe cases, the watch-and-wait strategy is obsolete. Surgical decompression is an urgent mechanical solution to a deteriorating mechanical problem. The natural history of DCM is defined by long, deceptive static periods, punctuated by sudden, irreversible, stepwise neurological declines. Dynamic and static mechanical forces induce vascular strangulation, selectively killing neurons in critical tracts. As seen in this axial cross-section detailing the relationship between the intervertebral disc, the canal space, and the spinal cord, timely anterior or posterior decompression definitively halts the ischemic cascade by targeting this exact anatomical area. By stabilizing the spine and restoring the internal diameter of the canal, surgery offers the best possible chance for meaningful functional rehabilitation. Recognizing subtle upper motor neuron signs early allows clinicians to outpace the ischemic damage, alter the disease's natural history, and preserve the patient's independence.